I would like to welcome everyone to AHRQ's National Web Conference on Clinical Decision Support Efforts that Assist Clinical Cognitive Processes. Though a few people are still logging in, I'm going to go ahead and get started on time. My name is Dr. Roland Gamache, and I'll be moderating the webinar today. I currently serve as the staff fellow in the Division of Digital Healthcare Research, which is part of the Center for Evidence and Practice Improvement at the Agency for Healthcare Research and Quality. The agenda for today's webinar should now be displayed. Please note that we are recording this webinar, and that the recording and the slides will be available on the AHRQ Digital Healthcare Research website in a few weeks. You'll be notified by email once they are available. We are pleased to have with us today an esteemed group of presenters. They include Dr. Zach Hettinger at MedStar Health, Dr. Anping Xie at Johns Hopkins University, and Dr. Yalini Senathirajah at the University of Pittsburgh. This webinar is accredited by Affinity CE. If you are interested in receiving continuing education credit for participating in this activity, information on how to claim your credit will be presented at the end of the presentations. It will also be emailed to you after the webinar. For the purposes of accreditation, let me note that AHRQ, TISTA, Affinity CE, and the panelists have no financial interest to disclose. Also, please note that no commercial support was received for the development of this learning activity. Just a brief note about questions. We have reserved time at the end of the presentations to address participants' questions. However, during the presentations, feel free to submit questions that you have for the presenters using the Q&A panel located at the right of the PowerPoint slides. Please include the presenter's name or the presentation order number, first, second, third, with your question. As a reminder, participants are in listen-only mode, so to ask questions, you will need to use the Q&A panel. This slide shows the learning objectives for today's webinar. By the end of this presentation, you should be able to describe the role of cognitive engineering for complex decision-making and problem-solving in acute care and understand the application of these tools as part of CDS development. You should be able to explain and apply the strengths of analytical and naturalistic decision-making and the design of effective CDS tools, and review the interaction design in electronic health records and how a composable approach helps solve problems of display fragmentation and the related impact on clinical cognitive load and clinical reasoning. And now it's my pleasure to introduce our first presenter, Dr. Zach Hettinger. Dr. Hettinger is an assistant professor of emergency medicine at Georgetown University School of Medicine. He's director of the MedStar Health Center for Biostatistics, Informatics, and Data Science, and director of cognitive informatics at the National Center for Human Factors in Healthcare. He is a board certified in emergency medicine and clinical informatics, and has funding from AHRQ, NIH, ONC, and FDA for research in health IT systems and EHR usability to reduce hazards in healthcare. And now, allow me to turn over control to Dr. Hettinger.
Thank you, Roland. And should get those slide control in just a second. There's always a little bit of a delay, and it looks like that's coming through. Looking forward to getting a chance to talk to everyone and then following up on any questions you have. So I'll be talking today about applying cognitive support to the emergency department using a human factors engineering approach. And there we go. This work was based off of the work I'll be presenting. Much of the work that I'll be presenting here is through an R01 that was funded by AHRQ, and then the other kind of general research funding from federal agencies as well as nonprofits up on there. So learning objectives for today will be giving a brief primer for human factors engineering and the potential value in healthcare, kind of quick couple of cases to kind of whet your appetite and try to convince you that there's a significant role here. Appreciate the role of cognitive support and the risk for errors in the health IT systems, and then looking at some case examples of how cognitive support can both help and also how that cognitive support is maybe not being met in some EHRs and other health IT systems. So initial piece here is a brief introduction to human factors, just make sure we're all on the same page. And just as a quick definition, that we think of another way to kind of describe human factors engineering is that we are designing for human use, and that in most of these cases, if not all of them, there's a human-machine interface. So there's displays that kind of we interact with as humans, and then our ability to control that display, whether it's using the keyboard, mouse, or if we think about other examples that I'll show in a second in the real world of how we kind of interact with our environment. And really, it's about optimizing the relationship between technology and the human users. We're designing the systems to match those abilities of what humans do really well and reliably and what we don't do so well and reliably, and making sure that we're matching those up as best as possible. It's data-driven and evidence-based, and it's been the norm in aviation, nuclear, and military industry for many, many decades. And over the last 10 to 15 years, been much more part of the healthcare environment, and we really want to leverage that in kind of the new health IT systems that we're interacting with. Let's see. Slight delay there in slides. Let me see if I can advance a different way. There we go. So in this case, we have a door, and the door, as we talked about just on the last slide, has a display. So we've got handles that are kind of speaking to us, as well as lots of other signs that are up there. And so typically when you walk up to a door like this, you're going to pull on those handles. And we know from fire code regulations that doors always are supposed to open to the outside. So if there's a fire, you don't have to pull and then people kind of run up to it. There's been some bad accidents out there. And so in this case, we know the door is going to go out, but the handle is saying to us, pull on me. And so if you ever come across one of these doors, whether you've interacted with it and pulled when you're supposed to push or push when you're supposed to pull, it's always a moment to kind of step back and reflect that we don't blame the users, we don't blame the individuals. We want to really come up with better designs. And we oftentimes see both in healthcare and in the real world that there is signage that often gets put up to kind of compensate for that. So at the top of the screen there, you see the push in all caps and vertical kind of font and layout that's kind of right in your face telling you make sure you push. And that usually is a sign that there's something wrong with the display and the controls. And so in this case, either other people have done it or maybe there's some sort of regulation. But we know from experience that people are going to, the control, the handle is really going to speak to people more than that sign is. And so people will continue to make mistakes over and over again. See, there we go. And when we, so again, blown up here right in your face, and we can always blame the user for missing that sign, but that's really not how we design safer systems. We don't blame the individuals, the nurses, the physicians, the frontline clinical workers. We design better systems for them to interact with. Slightly better design here is the push bar that you see in the middle, right? So you walk up to that, and that kind of gives you that display that this is how you're going to interact with it. People in general are much less likely to pull on that kind of push bar that you see on the other side of the door. So there, the form and function kind of match with the expectations. I love this example from healthcare where many people have interacted with these push plates when you're in the hospital and you're used to them and you know what to look for, but for the general public, they might not be as used to seeing them. And so oftentimes, again, as I mentioned, signs are a signal that there's an issue with the some sort of display and control. So the example on the left, you've got the sign up there to exit, press here, but really it's basically telling people how to operate the door down below, even though there's labeling on the button. And then over on the right-hand side, you see that people have pushed on the sign so often that it is worn out, and then some inventive person then took a pencil or pen and started to draw an arrow to point down to the button down below. So these are kind of, again, signals that the system is not quite working and maybe we can redesign it instead of adding more signs on top of signs. This case was posted on AHRQ's reports that basically outlines how the system and displays can lead to medical errors. In this particular example, a young, healthy individual was going in for elective knee surgery. Shortly after the surgery kind of started, as they were getting ready to induce the patient for a breathing tube to be placed, the patient stopped breathing. And that's not the normal course of events. Typically, patients would still continue to breathe on their own when the breathing tube is being placed, or just up to it. And in this case, the patient stopped breathing, and thankfully were being monitored, and they were able to manage the situation. They thought maybe this is a sensitivity to the pain medications the patient got. When they then looked into the kind of little trash can next to the anesthesia cart, they noticed that the patient had been given an injection of vecuronium, which is a long-acting paralytic, instead of the preoperative antibiotics to prevent postoperative infection. So you can see on the left here that the Ancef bottle and the vecuronium bottle both have red tops about the same size, and while the labeling is clearly different in retrospect, when they're placed in the anesthesia cart in this particular location, the two red top bottles are right next to each other. And so we know from human factors engineering that oftentimes, especially in high stress environments, just before the patient is being induced and intubated, and their airways under control, that the clinician might reach over and grab the wrong bottle, and if they're expecting to see one thing, there's going to be some degree of likelihood that they're going to misinterpret the labels. And this is a better example of very different labels, but sometimes same manufacturer for different medications will use very, very similar labels. So, even making the likelihood of that type of error happening much easier. So there are efforts out there to redesign these carts to make sure that the medications are functionally moved, or maybe even laid out in a horizontal fashion so that you can better see the differences between the bottles. When we talk about health IT systems, the picture by the late Bob Weirs, where this was a picture of organization, emergency department that was moving from the kind of traditional dry erase boards over on the left-hand side. There's kind of almost like an Excel spreadsheet type grid so that you could put in patient's name and chief complaint and all the kind of details about their care and coordinate amongst the nurses, physicians, and technicians. But on the right-hand side, this is soon after they went live, you've got one of those kind of big tracking boards that essentially is supposed to do the same function, yet you still see all the clinicians looking and using the dry erase board over on the left-hand side. Now, we know that some of those might be issues like what we define as user interface design or context-independent things, like font sizes, icons, colors, contrast, and layout. Much of that's been worked out over the last 10 years. But we start running into issues where the cognitive task support or the context design is not well supported. So these are things like workflow design, visualizations, memory aids, error anticipation, that oftentimes these dry erase boards and other systems that are in place have kind of been iterated on enough over time that they're kind of anticipating some of those issues, whether they're using little magnets or using shorthand notation that everyone has kind of gotten used to help restock the rooms or make sure the patient is seen by the attending physician before discharge. Those types of cognitive task supports have kind of been built into the systems, and when we go live with either new health IT systems or go from kind of paper to electronic, sometimes those specific cognitive tasks are either not studied or unrecognized or just not really kind of incorporated into the design in the initial layout. So that's where this project really kind of comes in, is trying to understand that cognitive task support. What are those pieces? It's not about the font size and icons and colors and contrast. It's about how do we support the cognitive needs of our users, and not just the physician, not just the nurse, but sometimes the communication between those individuals. This is a study that my colleagues and I put out several years ago, where we tried to understand the cognitive task support around common orders in the emergency department. So we looked at, in a simulated setting, this is across four different clinical locations, health systems, two different commercial EHRs, represented by one EHR was the kind of pink-purple, and the other was the kind of brown orange up there. We were looking at the cognitive task support of writing orders. And so how challenging was it for clinicians to order chest x-rays, MRIs for infections or cord compression, spinal cord compressions, various blood tests and medications. And so what we found was a huge range of variability, both within the health systems that had the same vendor, but across vendors as well. And so there were key pieces where the tasks were better supported not by one AHR versus the other, but also by different locations. And so we see a lot of variability by the length of the bars, the height of the bars, and then when we look at actually the performance on those tasks, we ran into even bigger issues. And so on the bottom right-hand corner here, we see the kind of cognitive support around prednisone tapers, a common steroid, where you take a dose and you reduce it every 2 days over the course of 12 days. We found that led to significant errors. So upwards of one location, 50% of the orders, electronic orders written for prednisone taper had errors in them, where there was miscalculations. Clinicians would have to pull out a calculator. They would do things by hand, and several of them just kind of gave up and said, "Look, I don't even write for this medication anymore because I can't do it. The cognitive task is just not supported with this EHR, and so I've used alternatives or just don't write for this medication anymore." So I hope I've convinced you that kind of overall background of human factors engineering, just kind of quick taste for that, and how that kind of cognitive support is critical to kind of safe and efficient task performance in the emergency department. And from here, we really tried to understand the cognitive needs and decision-making of nurses, physicians, and advanced practice providers in the emergency department. And then we really just focused on those particular groups, but know that there's a whole host of people in the emergency department and other critical care venues that play key roles as well. We used a mixed methods approach of interviews, focus groups, ethnographic observations, and cognitive task analysis, as well as using EHR data and prototype design to really understand how do we support these tasks and what would it look like, what are the lessons learned. We developed 3 different prototypes, and this is one of our first prototypes that we developed. And this is kind of focused around the challenge of ED triage and overall workload of clinicians. We know that, especially in larger emergency departments, that you might have multiple teams that work together, a team of a nurse or multiple nurses, advanced practice provider, or physician, as well as technicians and clerical staff. And we need to kind of understand the flow of work in the emergency department and overall workload. And so this was an attempt at visualizing that, so where each of these little bubbles is an individual patient, what room they're in, and overall how much work is associated with them. So what their severity score when they show up is, their number of labs, medications, and images that are currently pending on the patient, and allows us to kind of quickly visualize, okay, this patient or this attending physician is, got this much work versus this attending, and that can be important if a new critical patient shows up, or maybe it's kind of time for one of these clinicians for a shift handoff, and so, do we want to associate a particular new patient with a different group. And we built it so that you could also look at residents and nurses and workload. And this is all modeled after what physicians and nurses, especially charge nurses that are managing the emergency department, are already kind of doing in the back of their heads. Hey, new sick patient came in, let's maybe assign them to this particular physician or nurse or team because of X, Y, and Z. And so an attempt to kind of visualize that. We did run into issues of how do you quantify workload associated, the amount of work associated with a patient. So we did some interesting kind of real-time studies of individual patients and having clinicians, physicians and nurses rate how much work an individual patient was. And that could be due to things like how sick they are. So a patient that's got sepsis or needs resuscitation. It might also be someone that has behavioral health concerns. And so while we're not doing a lot of diagnostic testing on them, if a patient is very agitated and needs to be sedated or in a kind of secluded area in the emergency department, there can be a lot of workload. Even if in the EHR, there might not look like there's a lot of work, that individual patient. We also know that things can be high workload due to administrative concerns, like a transfer of a patient that might not be critically ill but needs a specialist at another hospital. That can be a tremendous amount of work for maybe the physician, but less work for the nurse because the physician is doing the phone calls and paperwork and so forth. So trying to kind of capture that into a score. And there was some follow-up research we did to help populate these boxes, not just with these kind of more basic algorithms like labs, meds, and images, but also some machine learning-based approaches to better quantify the amount of work. So this is an example of kind of cognitive support and kind of mapping the cognitive needs of the users onto a triage board so that we can better care for patients in kind of critical situations. The second tool that we developed was what we're calling the clinical event timeliner that helped better sequence the events of the patient in a time order. So oftentimes in health IT systems, there's siloing of orders and labs and medications, vital signs, documentation. Can make it really difficult to understand the relationship between those things. So if I look in the electronic medication administration record, the EMAR, I might see, okay, the patient got medications at this time and this time, and then I might have to either cognitively remember that time and date stamp, or I might have to write it down, use some sort of piece of paper. Maybe I've got some sort of chart abstraction sheet if I'm doing this retrospectively. But trying to understand the relationship between the tasks that are being done and the vital signs and lab work can be really critical and challenging to do in most EHRs. And so in this particular tool, we ended up kind of sequencing those things all together and then allowing kind of quick filtering both by date and time, as well as quick searching and filtering by the kind of type of data there that would allow individual users to look either back in time for that patient that's currently in the emergency department, or potentially in a retrospective capacity. We're doing chart reviews and trying to understand the response. Are there things that we can do better as an organization? Or if there's maybe a adverse event that happened, we want to better understand kind of what were the circumstances in which that happened. The last prototype that I want to touch on that we built based on the kind of supporting the cognitive tasks of our frontline users was what we were calling a patient-centered view. And so this was simulated data where we took a lot of the components after doing that mixed methods approach that I described earlier and kind of trying to key up the most important pieces based on discussions that physicians and nurses kind of are having on a regular basis. So in this case, there was, I just want to call out a couple of key pieces here where the experienced physicians and experienced nurses would often kind of have a rapport or kind of know how each other worked. But if you've got, let's say, a novice individual physician nurse, advanced practice provider, or maybe a traveler that's coming in, so someone who's experienced but maybe not used to this type of this particular hospital and the policies and procedures, that sometimes that communication would break down. So one of the key things that we had here on the upper right-hand corner, and then I'll blow this up in a minute, was around the plan of action. And that was kind of a key piece that got called out. I think, let me see, I've got to zoom in here. Another cognitive task that was really important was similar to the retrospective analysis that I was showing earlier around, looking back in the chart and kind of that really detailed view. This was a sequential view that allowed the clinician, physician, nurse, APP, to go through and understand over time what was the course of action. What was the result of, you've got vital signs that are kind of grayed out in the background, and then you've got different clinical events. When did lab tests come back? You can kind of visualize everything. On the left-hand side, you've got medications, labs, imaging, and so forth. And it also associates these with the overall course and track of the patient during their care. So the color coding across the top gives you a little bit of, okay, the patient's been in the waiting room in the beginning, and then they get moved into a room and they're waiting for the physician. Then there's an evaluation or treatment phase. And then there's a phase when it goes gray on the kind of top part here when the patient's either been admitted or discharged. And so you can kind of follow along their course, and maybe at some point in there, the inpatient team would take care. So a lot of data here, and it can be a little bit overwhelming, but this is an attempt where you can kind of flip back and forth between the data and make better sense of those time-based relationships. Again, something that's not really cognitively supported well here, and often can be a big challenge for the clinical team to understand the course of the patient. And then the main last piece here was around team communication. And I kind of mentioned earlier this plan piece in the upper left-hand corner of kind of what's the plan for the patient? Are we admitting them? Are we being discharged? As the clinician, I might be waiting to hear from family members. And if I don't explicitly say that to the nurse, but if I can write it in the plan, then when the family member calls back, then the nurse knows to kind of reach out to me as a physician or vice versa. Kind of planning for future actions and kind of knowing that that's what we're waiting on. And then the ability to kind of have an event feed over on the right-hand side that allows me to see, step away, let's say, to take care of a different critical patient, and I can come back and see what's going on, what are we waiting for. And there was some functionality also in here to kind of track did the nurse see this? If I wrote an order and the nurse is kind of pulled away into a different patient's room, maybe they didn't know that there's an order pending. So that might be a cue for me to go and talk to them, or it might be a cue, for them when they come back using the event feed here. So lots of different cognitive tasks that we're trying to support here, but the key piece being that kind of team communication and supporting those needs. Because again, oftentimes those things are lost in many of our health IT systems now if they're not explicitly called out. And then to kind of close things out, just wanted to give a couple of poor support case examples just to kind of show you where those challenges can be. So this particular screenshot here represents a basic metabolic panel, which is a very common blood test that we order on patients. And for any non-clinicians on the call, you probably wouldn't catch the fact that we would be expecting a patient's potassium level to show up right in the middle. So, towards the top here. So underneath the sodium, it is kind of a common sequence of how these are laid out, and the potassium level is missing there. And so we know from human factors that if that placeholder is in there that says potassium pending because it got lost in the lab or hemolyzed or any sort of reason why there might be a delay in a lab test, that clinicians are going to miss that because of the lack of visual cue, and they might make an action. They might discharge the patient. They might kind of admit them and not realize this patient's got a critical finding that might show up in 10 minutes, an hour, and unless someone kind of brings it back to their attention, it's going to get missed and cause significant problems. So errors will happen if we don't support those cognitive processes and the cognitive needs of our users. And the last example here is when we present lists of information to clinicians, it can be really challenging to tease apart. And so this one is a list of, in an EHR, of Tylenol orders. And so if you search for Tylenol or acetaminophen, you're presented with this list. Okay, which dose do you want to give? And we've seen time and time again where clinicians will choose the one, like the most common dose being 650 milligrams. They'll choose the third one on the list here, which is actually a rectal suppository, and not the seventh on the list, the sixth on the list, which is oral Tylenol. And when they do that, certainly a patient knows the difference between oral and rectal route. Obviously, the clinician and the nurse does. But in this case, the EHR, the way that the list is sorted, ends up inducing the error because we're not supporting the cognitive needs of our users. And while this doesn't cause a significant pain, although certainly would be embarrassing for patients if they got the wrong route, there are certainly medications that can cause significant harm or death if they're given via the wrong route. So we really need to pay attention to kind of the visual cues, going back to those displays and controls. So with that, just kind of summarize that we've talked a little bit about the brief primer on human factors, the cognitive support and potential for error, and the need for improvement in health IT systems and aligning with those healthcare processes and recognizing when the cognitive support of our users is leading to errors and how do we design that out of the system, not using kind of training and blaming and shaming individuals, but how do we design that out of the system. So with that being said, thank you so much for your time, and I will hand this off to my colleague and see, make sure.
All right, thank you, Dr. Hettinger. As a reminder to everyone, we will be taking questions after all the presentations. So please submit any questions you have using the Q&A panel. And now I'd like to move on to our second webinar presentation, which is being led by Dr. Anping Xie. Dr. Xie is a human factors engineer and assistant professor in the Armstrong Institute of Patient Safety and Quality in the Department of Anesthesiology and Critical Care Medicine at Johns Hopkins University. His research interests focus on using human factors and systems engineering approaches to improve healthcare quality and safety. He's been conducting innovative human factors research in various healthcare settings, for example, pediatrics, clinical care, surgery, and on a wide range of topics such as patient and family-centered care, HIT design and implementation, sepsis diagnosis as examples. And now I'd like to turn the presentation over to Dr. Xie.
Thank you, Roland. So it's my pleasure to join this web conference and share some of our work on human factors and clinical decision support. So as Roland says, I have been working on different topics, and for today, I would like to first give a brief introduction to human factors and ergonomics and its different domains of specialization, and then I will share some of our work funded by AHRQ on the use of human factors and ergonomics to facilitate the design and dissemination of a clinical decision support tool for blood culture decision-making in sepsis diagnosis. And instead of focusing on the CDS2 itself, I would like to talk more about the human factors work that we did to inform the CDS2 development, and specifically how we consider cognitive ergonomics issues in the integration of the CDS2 in EHR, and how we consider macroergonomics issues in the dissemination of the CDS2. Okay, so let's get started. So Dr. Hettinger just gave a nice introduction to human factors and ergonomics, and this is a definition of human factors provided by the International Ergonomics Association. And as human factors engineer, we are interested in understanding the interactions between human and other system elements, with the aim to improve both human well-being and system performance by designing the interactions. And human factors is a broad discipline consisting of different domains. And Dr. Hettinger just talk about the domain of cognitive ergonomics. And the other two domains of human factors engineering are physical ergonomics and organizational ergonomics, or what we call macroergonomics. And physical ergonomics is concerned with human anatomical, anthropometric, physiological, and biomechanical characteristics as they related to the physical activities. So some of the physical ergonomics issues in healthcare include, for example, working posture and workstation design, workplace layout and physical environmental design, and also physical tasks, such as patient handling resulting in work-related musculoskeletal disorder. And macroergonomics, on the other hand, is concerned with optimization of the larger socio-technical system. It looks at all components in the larger system and examines how individual functions work or don't work together. And one of the most famous macroergonomics framework in healthcare is the System Engineering Initiative for Patient Safety Model, or SEIPS model, which we will talk about later. And as I mentioned, I will focus on how we apply cognitive and macroergonomics to facilitate the design and dissemination of a clinical decision support tool for blood culture use in pediatric sepsis diagnosis. And the work was supported by two AHRQ grants. Okay, so some background information. So sepsis is a life-threatening complication of bloodstream infection that can lead to significant morbidity and mortality. And blood culture is a key test for sepsis diagnosis and treatment. But in practice, blood culture are perceived as a low-risk test and are used excessively, even when the pretest probability of bloodstream infection is low. So what usually happens is a physician gets a call from a nurse saying a patient has a fever. And most of the time, without looking for more information or going to the bedside, the physician will say, okay, let's order blood culture. And the overuse of blood culture may result in additional tests and necessary use of antibiotics, prolonged hospitalization, and of course, increased healthcare costs. So to optimize blood culture use, a group of clinicians at Johns Hopkins, including pediatric intensivists and infectious disease physicians, put together this blood culture checklist. And the objective of this checklist is not to tell the clinicians when they should or should not order blood culture, but to encourage them to review and examine the whole picture of a patient before they make a decision. And the checklist was first pilot tested on the PQ at Hopkins, and the preliminary data show that the introduction of the checklist resulted in a reduction in the total number of blood culture collected by 46%, and in the percentage of blood culture collected from central line from 73% to 40%. And since then, I was involved as a human factors engineer in the team to help the team use a human factors approach to sustain the use of the blood culture checklist by integrating it into EHR and then disseminate the checklist to other healthcare settings. And let's talk about each of these efforts. So first, integration of the checklist into EHR. So why did we propose to integrate the checklist into EHR? So although our preliminary data show that the paper-based checklist could reduce blood culture use, we observed some practical challenges to using the paper-based checklist. For example, the checklist is stored in the physician workroom, and the clinicians may not always have access to the checklist when they order blood culture. And in addition to that, the checklist includes different pieces of information that a clinician is expected to review before making a decision. And a lot of this information is available in the EHR, but the challenge is that it is time-consuming and challenging for the clinicians to extract all these information from the EHR. For example, the first items on the checklist is temperature. So the clinician needs to know not only the current temperature, but also the trend and source of the temperature. And in EHR, there are 3 places where the clinicians can get information about a patient's temperature. The first place is this summary sheet, where you can find the highest and lowest temperature of a patient, but not the source and trend of temperature. And the second place is this flow chart, where you can find the temperature and the source of the temperature at each time point. But in order to get the trend, you need to scroll down the flow sheet and mentally compare the different values. And the last place is this diagram, which visually show the trend of temperature. But again, there's no information about the source of the temperatures. So this is just one piece of information on the checklist, and there are about 50 items on the checklist. So we need a better way to extract and synthesize the information for the clinician. So to inform the development of this electronic tool, we conducted critical decision method interviews with different PQ clinicians at Hopkins to understand their cognitive work associated with blood culture decision making. And the critical decision method interview is a cognitive ergonomics technique that is commonly used for eliciting tacit knowledge in challenging and atypical complex situations. And to prepare for the interviews, we review patient charts on a weekly basis and purposefully identify cases where a patient has a fever and a blood culture ordered, a fever but no blood culture ordered, or no fever but a blood culture ordered. We then invite different clinicians involved in the identified cases to participate in the interview. And during each interview, we ask the participants to review and discuss 1 to 3 cases. And this is a tool that we developed to facilitate the interview. So for each identified case, we prepare a brief summary. And after reviewing the summary, we'll ask the participants to draw critical incidents on the timeline. And for each critical instance, we ask questions such as who are involved, what information were collected, and what tools and technologies were used. And based on the interview data, we identify 4 steps of the blood culture decision-making process, which are knowing patient history, recognizing patient with change of status, ruling out causes, and making and validating decisions. And for each step, we examined how it was performed, what the potential challenges could be, and what were the implications for the design of the CVS tool. So for example, the first step is knowing patient history, which can inform the other 3 phases. And by taking care of a patient, clinicians usually develop a long-term knowledge about the patient. And in addition, they also review patient's condition on a daily basis through, for example, shift change or rounding. And one of the potential problems is if I'm a new clinician for patients or if I cover a patient for others, I may not have this long-term knowledge or I may not review the patient's condition on a particular day. So it will be helpful to have a tool that summarizes all relevant information for me. And also, not all information is available in the EHR. So in addition to summarizing a patient's condition, it would also be helpful if the tool can remind the clinician to look for information from other sources, such as doing bedside exam or talking with the bedside nurse. And the next step is to recognize the patient with change of status. So in order to do that, clinicians may use an analytical approach or an intuitive approach. So the analytical approach focuses on the change of clinical indicators, such as temperature and other vital signs. And the potential problems here is that the clinician may focus only on the current status, but not the trend. So for example, a clinician may notice that a patient has a fever, but the fever can be a new fever or a persistent fever. For persistent fever, maybe there's no need to draw a blood culture. And also different patients may have different signs or threshold. For example, for most patients, we use 38 degrees Celsius as the threshold for fever. But for patients on ECMO, they may never get to 38. For patients with brain injury, the clinicians usually do not want to wait them to get to 38. So if we use 38 as a threshold for all patients, there may be a problem. And in addition to the analytical approach, there are also cases where clinicians recognize a change of status by matching a patient's condition with the clinical patterns they learn from experience. So we call this approach an intuitive approach. So for example, we heard a few experienced nurses told us that in some cases, the vital signs did not change, but they just felt that there was something wrong with the patient, so they informed the physician. So a potential problem is that some clinicians, especially those with less experience, may focus only on the clinical indicators and not be able to use an intuitive approach. And in this case, they may miss the opportunity to recognize a change of status. And finally, so no matter which approach they use, analytical or intuitive, so most clinicians we talked with told us they seldom recognize a change of status by reviewing the EHR. So usually it is the nurse at the bedside who informs the physician, or the physicians walk by a patient room and recognize a change of status. So some of the implications for CVS design here include providing information on both current status and trends to facilitate analytical thinking, learning and building a library of clinical patterns to facilitate intuitive thinking, and alerting clinicians about change of status. All right, so after recognizing a patient with a change of status, clinicians need to rule out potential causes of the change. So they need to consider different potential causes, collect more information to get a whole picture of the patient, and then matching the patient condition with a typical clinical representation of each cause. So, for example, if a patient has a new fever, the clinician needs to think about what are the potential causes of the fever. Is it because of bloodstream infection or inflammatory response to surgery, or simply the patient's wrapped by a blanket? So in order to rule out these causes, the clinician may need to collect more information by reviewing the EHR, conducting physical exam at the bedside, or talking to the bedside nurse. So some of the potential problems include the entire step of ruling out potential causes is missing. And as I mentioned, the clinicians just order the blood culture reflexively. And also clinicians having limited knowledge about potential causes and associated clinical representation, or clinicians having limited time to collect additional information from different sources. And last but not least, clinicians mismatching the patient condition with the clinical representation because of incomplete information. And the implication for CDS design includes to indicate all potential causes, and also to indicate additional information needed and the source of the information. And finally, the clinician attributes the change of status to a cause and make their decisions on either ordering or not ordering blood culture. And usually it is the residents or fellow who make the decision, and they usually run their decision by the attendings. And sometimes they may also run their decision by the nurse, or the nurse may verify blood culture order with the physicians. So some of the potential problems include, so first, junior physicians making decisions without the involvement of senior physicians, or senior physicians not challenging decisions made by junior physicians because of mutual respect. Junior physicians not challenging decisions made by senior physicians because of hierarchy, or nurses not challenging decisions made by physicians. So to address some of these issues, people suggest to include a forcing function to get approval from senior physician, while others emphasize the need to balance between a hard stop and the clinical needs, meaning we want the junior physician to run their decision by senior physician, but in case of emergency, they should still be able to do what they need to do. And informed by the findings from the clinical decision support, informed by findings from the critical decision method interview, we work with different groups of clinicians and IT experts to develop the electronic tool. And here are some prototypes. And now we are trying to extend the CDS to address the entire process for sepsis management, including diagnosis support, guidance on blood culture collection, recommendations on antibiotic use, tracking of patient status and lab results. Okay, so that's about the integration of the checklist into EHR. In addition to that, we also disseminate the checklist to different healthcare settings. And we use the system engineering initiative for patient safety model to guide our dissemination work. So the CvS model highlights the interactions among work system elements and levels and the dynamic impact of individual work system elements on the whole system, and the links between work system, care processes, and system outcomes. And according to the CvS model, the healthcare system consists of multiple people performing different tasks using various tools and technologies in a physical environment and under certain organizational conditions. And these interrelated work system elements influence the care process, which further influence patient, employee, and organizational outcomes. So in other words, the blood culture checklist is only one element of the work system. And to improve the blood culture ordering practice, we need to optimize the entire work system. And the dissemination process includes two steps. First, the checklist was adopted by 2 hospitals. And to facilitate the implementation of the checklist at these 2 hospitals, we conducted a work system assessment at each hospital to understand their current blood culture practices and identify work system factors influencing their blood culture practices. So we spent 2 days at each hospital and conducted face-to-face interviews with different groups of PQ clinicians. And based on the interview data, we identified various work system factors that can influence blood culture decision making. And because of time limits, I'm not going into the details. But if you are interested, here is the paper that's where we present the interview data. And so after the work system assessment, we shared what we learned from the interviews with the 2 hospitals and worked with them to adapt the checklist to their local team and patient populations, and also to develop other strategies to facilitate the use of checklist, including using the checklist to facilitate clinician communication. For example, when the nurse called a physician about a patient having a fever, they may review the information on the checklist together. Also educating clinicians about good blood culture ordering practices and the importance of teamwork to blood culture ordering decision making. So both sides provide training to their staff. and also providing clinician feedback on their blood culture ordering practices. And one of the hospital even created a contest among their physicians regarding their monthly blood culture use. And of course, securing leadership support, identifying unit campaigns, and also changing unit cultures. And the adoption of the blood culture checklist at these two hospitals also achieved a 20 to 40% reduction in blood culture use. And following the small-scale dissemination, we are currently working on another AHRQ-funded project to disseminate the blood culture checklist to a large collaborative consisting of 15 hospitals. And we apply the participator ergonomics approach, which emphasizes the involvement of people in planning and controlling their own work activities to facilitate the large-scale dissemination. And each participating hospital convenes a local quality improvement team led by at least one physician champion and one nurse champion. But given the number and distance of the hospitals, we could not visit each hospital and conduct in-person interviews with local clinicians. And also with limited capabilities and resources, the local QI team could not easily conduct their own work system assessment either. So we adapt our interview-based work system assessment to a survey-based work system assessment, and administer the survey with over 350 clinicians from all 15 hospitals. And we then support the local QI teams through monthly individual and group calls to adapt their, to develop their own clinical decision support tool and redesign their work system and processes. And during the individual calls, so we work with the local QI team to address their unique challenges. And during the group calls, the participating hospitals share their experience with each other. And we are now working on analyzing and reporting the result of the larger collaborative. And with that, I think that's all I have for today. And here are the studies I cited in the presentation. And if you're interested in our work and once you have further conversation, please feel free to email me. And with that, I will stop sharing and hand it to our next speaker.
Thank you, Dr. Xie. Again, please feel free to submit any questions you have using the Q&A panel at this time. I'd like to move on to our final presentation for this webinar, which is being led by Dr. Yalini Senathirajah. Dr. Senathirajah is an assistant professor in the Department of Biomedical Informatics at the University of Pittsburgh Medical School. Her main area of research interest is improving the design and usability of EHRs and health IT systems in general, using a novel paradigm based on giving non-programmer clinicians more control to create tools and interfaces via a drag-and-drop flexible platform. Her other areas of research interest are using informatics for patient-consumer engagement, particularly to improve health equity in minority and underserved communities, global health, and analytics to improve healthcare. And now I'd like to turn control over to Dr. Senathirajah.
Years, and what we call the composable approach, which is giving clinicians more control to design the interface, and especially as it relates to cognitive support and the display fragmentation problem. So usability is still problematic in many EHR systems. And in recent history, we've seen 3 examples where a simplifying technology let a broad range of people do things they couldn't do before. The invention of the graphical user interface let a lot of people use computers. The browser let anyone use the internet. And the advent of word processing was the first time in the history of printing where you didn't need a lot of skill to create perfect documents. So we wondered, well, what if clinical users could create and share some of their own UI and tools, there is a literature from other studies of other types of work that show that people do use object arrangement to facilitate their cognitive processes. So commercial EHRs are predominantly menu-driven. This is an example taken from a real UI. And only the areas in red are the actual data a person has to look at. All the rest is navigation. And navigation in these systems can be very complex. That leads to a lot of clicking and screens. And this has led to clinician organizations calling attention to some of the safety and other issues. And EHRs have been implicated as contributing to burnout. So when we decided to try and build a platform that would let the clinician have more control, there were certain philosophical points. One is that we felt ideally any element should be available to be composed and shared, the ability to share things you create as part of the model. We felt that customization in a system that needs to be customized is different than other kinds of changes where the code is being changed, and that customization should be easy. So we took a sort of drag and drop object manipulation approach. We also felt that there's an assumption in most computing that we can model a process in advance and then build the code, but that in healthcare there are situations that arise where the end user has knowledge of the context and other needs at runtime that can make it different. We also wanted to be able to incorporate third-party visualizations. And in saying that we're giving control to the end user, it doesn't necessarily mean complete freedom, but if you have a flexible system, it means that control can be shifted to being a policy matter. So in many systems, the navigation tree is quite complex. It can be written down like this. And if we wrap it around in a circle, we can get a visualization of the whole tree. So here, the black elements are the actual clinical data that the person needs to look at, but it's fairly complex to get to, and in this case, takes 37 clicks. This is another example from another EHR, and this affects cognition because we know from cognitive science that perception, attention, and memory are limited cognitive resources, and therefore, if you're spending some of them on navigation, there's less available for the real task, which is clinical reasoning. Screen transitions often also require hand-eye coordination, and so that's also interrupted, and you get a situation where a person is thinking about the clinical problem and then getting interrupted, having to look for more data, and so on. And this imposes cognitive load when we have many screens. In most situations, because the information location is fixed, we have one screen, some information is relevant. We have another screen, other information is relevant. And then we have to combine it in our minds often, and that can lead to cognitive overload, sometimes forgetting things, and then having to review them or write them down. And we know from log file studies of people using EMRs that they do, in fact, repeat viewing things often, up to 5 or 6 times in a single session. So this depicts on the left what I just talked about, people having to retain things in memory between screens. On the right, if you are able to assemble things externally on screen, then in theory, you wouldn't have to retain as much in mind. And so we felt that this approach might lead to reduced cognitive load. So we built systems that allow the person to assemble things, different kinds of information in the same screen according to what they think is relevant. We've been through a few iterations. The visualization in the upper right here is a third-party visualization called AHRQ. The green circle represents the normal range, and so it's made to be able to see at a glance how many things are out of range. In this system, also setting up custom things like the coagulation tracking panel can be done in less than 30 seconds. This is a COVID-specific display. So in studying this, we had some early findings. One thing is we found when people are given this kind of system and allowed to assemble whatever they like on screen in order to assess a case, their interactions fell into 3 general categories. Some people would just assemble whatever they felt was relevant on the same screen very quickly and come to a diagnosis and make decisions. Other people were much more structured and would arrange things and color code them and have certain regions assigned to certain things and so on. And the third strategy, which we call dynamic stage, was the people would interact with elements and move them around as they were thinking. All three strategies tended to use juxtaposition to help people with their thinking. And there were various ways they did this. They could put things in order, for example, the order of severity of problems. They could put things together in order to serve as reminders or to compare two elements. They could color code things in order to remind themselves in future of things like severity or just as a category and so on. We also found a 77% decrease in repetitious navigation, and taken from log file studies taken over a population of users caring for the same patients, this could lead to up to a six-fold time savings if they were sharing screens. People also said that one of the ways they anticipated using this was to jointly standardize their displays so a unit team could get together and on their own without having to ask a programmer standardize what they thought they need to see. We found similar diagnostic accuracy. We're continuing to work on this between people using the two different systems. And some people said they also thought there was a checklist effect, that if they had assembled a screen for certain types of workups and so on, that it would then serve as reminders. In general, we got very favorable comments from people who had used it, mainly because they liked being able to look at things together and to be able to arrange things according to their tasks. They also, some of them felt it was quicker and so on, and they mentioned a subjective sort of it was easier to do. But we also got criticism and concerns about what if you give people this kind of control, what if they omit something and then share it and it could lead to an error? And this made us think more deeply about the specific mechanisms involved, and we realized that there are advantages and disadvantages, but there could also be means by which this is a safer approach. One of the overarching things is that if you have a flexible, easily changeable system, it doesn't have to be in suboptimal configurations for very long. So we continued doing experiments, and I'm going to describe some of these here. One of them was we did some eye tracking work. Eye tracking is a technique that by using certain types of cameras, we can determine where a person is looking on screen. And they can also measure pupil dilation, which is correlated with cognitive load. So there's software that can show cognitive load traces. It's used in aviation and other usability studies. And we had people doing 6 typical tasks in the regular EHR with real patient cases. And we were interested in what areas of using the EMR, especially cognitively loading. What we found is that long document lists, often people are presented with long lists of links that they have to double click, go into a note, scroll to the relevant sections and so on. And this was one of the most loading things, as was flow sheets filling and ordering. For the long document list, ICU and ED docs also mentioned they felt there was a safety issue because there was often not enough time for them to view everything they should, and so they could miss things. In interviews, people also mentioned pain assessment documentation and admissions as things they found especially problematic. So once we know these things, we can come up with different design patterns. We have more on our website. So instead of having long lists of links, we can add configurability so that the system could aggregate the things that the person really needs to see. And similarly, for flow sheets, there are many other ways of navigating large sheets that could be more conducive to ease of use. We were interested in omissions and errors. So we did a study where we gave clinicians 4 patient cases, 2 of which had a deliberate error or omission, as well as a confusing and contradictory note section. And we were interested in, would they detect the omissions and errors? What would they do? How would it affect their diagnosis and so on? What we found is that they either detected and mentioned the omissions and errors in their think aloud, or they didn't mention them, but they still made the correct diagnoses and still handled the omissions. So for example, if a lab test was missing, they would say, this test should have been ordered, I'm ordering it now. If the error was designed to lead in a different diagnostic direction, they would include that in their rule-outs if it was needed. Because they were being presented with composed displays based on what other people did, as you might expect, it also took a shorter time than either composing the displays themselves or using the conventional system for the same cases. We also did a crossover study of subjects with 4 cases, appraising 2 of them in the experimental system and 2 of them in a commercial ambulatory system, with a think aloud protocol. And what we found again is that they made heavy use of juxtaposition. So here the person has juxtaposed 3 notes in time order and would scroll to the relevant section so that she could trace what was happening with the patient's hypertension. And she also used it to make some inferences about the patient's adherence. Here the person placed the 1 note centrally and used it to frame their subsequent information search in the labs, and also to appraise the chest X-ray. We see from the time sequences that, so the top time belt there is a case in the person using a conventional system, and as you can see, they've repeated things several times. It's much more fragmented. The same case appraised in the experimental system is more consolidated. They spent fewer transitions and more time in doing each thing. We find some common patterns in the way people organize things. So one very common one was having orienting materials on the left. For example, a 2-line summary of their demographics and the presenting problem and current note, data down the middle, and then action and communication items on the right. The figure in the lower left is an example of someone juxtaposing things in order to calculate a ratio. It's also important, though, to have defaults. So if people are creating different displays and sharing them, that could increase cognitive load because the receiver isn't used to it. So we recognize the need for defaults and also for landmarks. So this is an example of having landmarks where people would know exactly where to look, even if the display layout was somewhat different. So people's reactions and interview resulted in saying that the main advantage of this was being able to see all relevant data together without having their thinking disrupted. They also mentioned communication with colleagues and future self informally, so they could arrange things so that when they came back to the case, it would be arranged in a way that made sense to them, would convey to them what their reasoning was and the options that they planned. And there is a sort of post-it note feature in this interface, and they mentioned having an unofficial side channel like that was important, both for communication with colleagues as well as for themselves. Again, they would jointly standardize what they need and found visualizations conducive to pattern detection. So the main advantage they conceived of was that being able to fit things to their clinical reasoning for different tasks. And the more variable the patient's load was, the more useful they felt having this done manually would be. So in CDS, the 5 rights of CDS are having the right information at the right time to the right person via the right channel and the right format. And we feel this approach can be useful in 3 of those. And I think it's worth reflecting on what if CDS could be set up faster, if you can combine things that can need to be seen together, like AI recommendations with the other clinical data or patient-reported data together with the EHR data. So there are many different pros and cons of the conventional versus composable approach. I'm not going to go through them all in the interest of time. But we were also interested in the speed with which one can compose things. I think the pandemic has brought to the fore, and we did some work on this previously before the pandemic, when new needs arise, having a flexible system can be useful both in terms of the variety of things one can do and the fact that one doesn't know what new needs will take place. One of the other very interesting things about this work is the new use cases that others have suggested. So, for example, transitions of care, where you could allocate different information according to different people's roles, or, for example, in ED, being able to surface certain types of information to help the decision about whether to send the person to a trauma center. And I wanted to call attention to, we found NASA has used this kind of approach in its mission control software. They similarly have needs for extensibility and high reliability and security, and they found that modularizing things, vetting them for security, and then giving them to their end users who are also scientifically trained turned out to be the most useful way for them to meet their needs and create new tools. And some of their clients also found quite significant time and cost reduction in creating new software. So the things about decreasing cognitive load, being able to juxtapose information used together, and one might consider permitting users to have ways to arrange data, but this must be presented as an option and not a burden. The shareability of different kinds of tools and composed interfaces, and having a left-right pattern of orientation, data, and then decision action. Being able to have different information types on the same page is valuable, as are some third-party visualizations. And I wanted to call attention to, from our research, the idea that user control may have morale effects. Several people mentioned this, although in our design, we don't expect everybody to compose things, and many people say they're not interested in composing things. They want to borrow the compositions of their colleagues that they like. The idea of users having more control seemed to have a sort of a positive effect in itself. Thank you for your attention. We are looking for collaborations and vendors also, if you're interested, we would be interested in collaborating. We have many papers at ahrlab.org, and I'm grateful for funding by AHRQ and all our current and past lab members. Thank you very much.
Thank you, Dr. Senathirajah, and thank you again to all of our presenters for the very informative presentations. As a reminder, please submit any questions you have for any of our presenters using the Q&A panel. This concludes the content portion of the webinar. We have a few minutes left for questions. If you can type them into the Q&A section of the WebEx portal. Though we may not be able to get to them all today, we will provide responses to all questions in writing. You will receive an email once these responses are available. I'm trying to advance the slides here. So now I have a few starter questions. The first question is for Dr. Hettinger. Dr. Hettinger, how does health IT bloat over time contribute to potential errors in the EHR, and what can be done about it to support the cognitive needs of the users?
Thanks, Roland, for that question. We're definitely seeing this more and more, and I think that the example that I had up there around Tylenol and kind of over time what happens on the back end of the EHR And so whatever you want to call it, whether it's bloat or just kind of management or data governance, has a huge impact on the usability. So hazards that weren't there when the system was implemented, that develop over time, we really do need tools on the back end of our health IT systems that help those that are kind of implementing it at the on the front lines to manage those things. So instead of adding more and more content, are there ways that we can refine, ways that we can figure out if some of that content is already in the system, whether it's orders or other functionality. We're seeing, some of these third-party tools. We're seeing kind of ability to do patient-reported outcomes. How is that data getting put into the system? So we want to make sure that the back end of the system also has that kind of support to identify these types of issues that could lead to significant hazards down the road. And that's really a combination between the health systems, the frontline users, and the vendors, and then potentially, third-party tools all working together, because there's not one particular group that can solve it on their own.
Thank you, Dr. Hettinger. A question for Dr. Xie. There have been increasing efforts focusing on early sepsis prediction. How many human factors contribute to these efforts?
Thank you, Roland, for the question. So actually, I was involved in some of the effort to use, for example, artificial intelligence or machine learning to predict sepsis. But as a human factors engineer, I think the key is still how the predictive tool fit into the cognitive work and the larger work system of the clinicians. So first, as I mentioned in the presentation, the decision-making process for sepsis diagnosis include both analytical thinking and intuitive thinking. So the sepsis prediction tool as an analytical tool may not be able to address all the challenges. And in addition, so in our work on sepsis prediction, we talked with a few clinicians who mentioned that even they receive an early notification from a predictive tool about patients having a potential to develop sepsis, they would still wait for what they call sign of sepsis to order blood culture and initiate antibiotics. So I guess in addition to predicting sepsis, what is also important is the guidance on what the clinician should do after they receive the alert.
Thank you, Dr. Xie. And the next question is for Dr. Senathirajah. What are the biggest issues in incorporating composable systems into EHRs, and what would the architecture be?
So we conceive of it as being a layer in the sort of on top of the EHR. So that would be using FHIR or other API type systems. And then we think it's important, especially in experimental situations, to have the regular system available. But it would be a sort of something like a smart on FHIR app, but much more extensive in the types of data that would be included. I'm not sure if I've answered the question.
Super, thank you. And the next question is, again, for Dr. Hettinger. Why do health IT systems not provide sufficient cognitive support to frontline clinical staff?
I think it's a complex question because of the individual needs of those users that are going to be different in potentially different health systems, in different environments, under different circumstances. I think some of the examples were good by the speakers here around, what does it take for managing sepsis, for COVID patients, and so forth. So it's again pretty complex. And my research team and I believe, that again, it needs to be something that's sought out by both the healthcare institutions, the clinicians, and the vendors, and whether we can share this information. So it doesn't help us if, the problem gets solved by one particular health system and one particular vendor working together, but can we share those lessons learned and then make the system safer by spreading this work around and not just relying on a single group or a single individual to be doing it.
Thank you, Dr. Hettinger. Dr. Xie, a second question for you. When you disseminated your blood culture checklist and tested its effectiveness in improving blood culture use in the larger scale, how did you find the balance between intervention, standardization, and customization?
Okay, thank you, Roland. So actually, we did not standardize our intervention. So we consider our work as a quality improvement work, so which is a little bit different than the traditional clinical trial. So what we try to standardize was the dissemination process. The local team has the flexibility to develop their own CDS tools and also adapt their own work system and processes. So for example, all of our hospitals develop a CDS tool, but some of the sites develop a checklist to screen for signs of sepsis. Some sites develop a flow chart to illustrate their blood culture decision algorithm. And some sites develop both a checklist and an algorithm. And in addition to the CDS tool, there are also hospitals who make further changes to their local work system. For example, revising the institution policy to standardize blood culture ordering practices, or integrating a discussion about blood culture into the daily rounding process, or introducing a peripheral blood culture kit, and also developing education materials for family. So in short, we didn't standardize the intervention itself. Roland?
And Roland, you may be muted.
I am. Thank you. Thank you. Dr. Senathirajah, would you please tell us just a little bit more about the reactions of the clinicians that you work with, and also what some of the other use cases that they suggested as well?
Okay. So most of them, after using it, were quite favorable. Some were not. You know, occasionally you'd get the person who said, I hate the idea of customizing my own things and so on. But generally, once they'd experienced it, because they liked the ability to be able to see things together and to have some control. And then some of the use cases were also things like various nursing-specific uses. In emergency, I think I mentioned being able to bring to the surface data that you would need to make decisions about whether to send it to trauma. Specific specialty needs. So some specialties prefer to have their labs in a certain way or have trends displayed in a certain way and so on. And things like transferring patients between institutions where you would have different people in different roles assembling things in different ways. Those are some of them.
Great, thank you. And then one final question for you. What is the difference between the composable approach and, for example, the Smart on Fire apps or templates?
Ours, we're taking a more comprehensive view, so we think that any element should be available because we don't know what needs people are going to come up with. So Smart on Fire tends to focus on we're meeting a particular need, which usually has a narrow set of data and is trying to display it or do decision support or something for a specific narrow purpose. We think that this should be sort of more like the word processor that you can create anything you might need from. That's a bit overstating it, but we felt that this should. We're starting from a sort of bigger set of things, and that it's also, instead of meeting a sort of specific need, say for calculation of a certain parameter, we're focusing more on how can you accommodate the sort of entire set of tasks that a person might need to do an appraisal. And also the idea that you have the whole set of data available so that you can compose it on, when you need it.
Great, thank you. I'm going to move now to the questions that were submitted. For Dr. Hettinger, does any of the work you did increase documentation time by providers and staff? And how much have you explored the effects of interfacing with these types of functions, like with the smartphones, in-house communication devices, et cetera?
A lot to unpack there. So the work that I presented here were all prototype designs based on the mixed methods approach. And so we didn't have the opportunity to put them into the real world setting and then check for changes in time. What we did try to do, though, is incorporate it to techniques and things that are already being used. So for instance, the plan piece that I mentioned, in most emergency department tracking boards that are used, that are in kind of that mock-up of the dry erase board, there are free text areas. And so one of the standards, or not standards, but oftentimes clinicians will then put in the plan of action. It might be acronyms, it might be really shortened, but essentially it kind of is already getting put in there. And so we provided more space so that that could be flushed out and specifically called out, but oftentimes that's already being done in the EHR. So the goal wasn't really to add a lot of cognitive burden or a lot of cognitive tasks, but free up and make it easier to have all the information either in the right place or have placeholders for those clinicians that do want to fill it out. So definitely avoiding the kind of mandatory, you must fill this out, you must do that, and adding a lot of overall burden. And the last question, the research I presented here, we really didn't focus much on smartphones and communication. There have been some other research our team has done in that space, and it's constantly shifting. Even within my clinical practice, we have switched between multiple different kind of smartphone portable devices. So it's definitely a fast-moving place that we need to acknowledge the communications that happen, whether it's via text messages in a kind of a non-approved kind of workaround strategy, or kind of fully approved integrated devices into the EHR.
Thank you. I think we can squeeze in one final question. This one is for all the panelists, but what projects or scenarios should human factors engineers be involved in, and at what stage of the project?
I can jump in on that. I would say all of the above. That there's rarely a situation where there wouldn't be some benefit from human factors engineering thought or approach. We definitely work, my human factors engineering team that's integrated into our health system at MedStar Health. There are certainly circumstances where just asking the right questions or making sure we're integrating end user feedback, some of these kind of very basic principles in the human factors world can really help improve that kind of work system and function from the baseline. I think that the integration of human factors into kind of informatics approaches is critical, but it doesn't need to be a barrier where everything has to be run by, through those engineering principles. So sometimes it's a little bit of give and take of time and energy and bandwidth, but oftentimes there is a role to be played in most processes.
Thank you. Does any of the other speakers have any comments to add?
Yeah, this is Anping. So I agree with what Dr. Hettinger just said, and maybe my answer is a little bit biased, but I think any system involving a human being, the human factors can contribute to. And actually we did a systematic review on how human factors may apply to healthcare quality and safety. In that review, we divide the quality improvement process into analysis, design, implementation, and evaluation. And we provide examples of how human factors can contribute to each of these stages.
And I think we've reached the end of our time. I'd like to thank everybody for attending this webinar. For those interested in continuing education credit, please see the URL on this screen. You will need to select today's webinar, which will be indicated by date and title to claim your credits. You have 14 days to claim your continuing ed. Upon exiting today's webinar, AHRQ is also fielding a brief evaluation, and we hope that you will complete the survey and share your feedback with us. Thank you very much, and thank you for attending today's webinar.